everybody, I'm Savan from Inspiring Minds, and today we are going to discuss another type of parasympathetics that is called as neuromuscular blockers. Neuromuscular blockers are currently used in the clinical practice a lot because, for example, we are going to do some surgery, and in surgery you want all the muscles to be relaxed, obviously, and you are doing the intubation that is called as the endotracheal intubation, in which you are putting a pipe inside the nose and in the trachea to provide oxygen to the lungs during the surgery. So every surgeon has a wish that the patient muscles are relaxed, and for that they use neuromuscular blockers mostly in each and every surgery to be relaxed during surgery and to do all the invasive procedure they want to do. So neuromuscular blockers, how do they act? First of all, a normal physiology I'll talk about of how the neuromuscular conduction is there, how the muscle contraction occurs. Here is a somatic neuron. Yes, we have already discussed that the somatic neuron secretes acetylcholine, and this acetylcholine binds to the NM type of the nicotinic receptor that is present on the muscle. This is the muscle end plate, and here is the nicotinic receptor. As soon as the acetylcholine binds to the nicotinic receptor, what happens is this binding causes the sodium channels. Here are the sodium channels that are present on the muscle, and these sodium channels open up, okay, when the ligand binds to the NM type of nicotinic receptor. Ligand is what? Acetylcholine. These sodium channels open up, and these sodium channels causes the muscle membrane. We know it is what? Depolarization. Yes, the resting membrane potential of this membrane reaches the threshold, and then the depolarization occurs. Okay, so this sodium comes in, and this causes the depolarization of the muscle membrane. Then this depolarization, when it occurs, it causes the calcium to come in, and the calcium causes the muscle contraction by fusing together the actin and the myosin filaments by cross-linking them. So that is the normal physiology. What we are attaining here by the neuromuscular blockers is that we don't want this depolarization to occur, or any procedure that can stop the muscle activity. So what can we do? We can just block the NM type of the receptor. Yes, and then if we block NM type of the receptor, there will no depolarization of the muscles. So now we are discussing the two type of the neuromuscular blockers. ठीक है, they have different mechanism of actions. We'll discuss it. So this basic physiology should be known. So पहला जो है neuromuscular blockers, they are called as non-depolarizing. Non-depolarizing, as it is clear from the term that it is not causing the depolarization of the muscle membrane. Okay, depolarization के लिए क्या जरूरी है? Acetylcholine का NM type of nicotinic receptor से bind करना, then only depolarization can take place. But depolarizing neuromuscular blockers, what do? They are competitive antagonist of the receptor, NM type of the receptor. So these non-depolarizing agents, they bind for the receptor, they compete for the receptor with acetylcholine. Here the acetylcholine also wants to bind with the NM receptor, nicotinic receptor, and these agent, non-depolarization agent, they also want to bind with the receptor. So one of them is going to bind. That will depend on the concentration, whose concentration is more. So if you are giving this agents, non-depolarizing agents, in a good concentration to the patient, they can exceed the concentration of acetylcholine in the cleft, and they can bind to the nicotinic receptor present on the muscle. If they bind to the nicotinic receptors present on the muscle, there will be no depolarization produced in the muscle, and what will happen? The muscle will undergo paralysis. Yes. So what is the route of administration of the non-depolarizing agents? Is IV or an IM. Mostly we give them through the intravenous route, but sometimes we can give them through intramuscular route when we don't want the action to be prolonged, because intramuscular delivery of the drug shortens the action of the drug. Okay, then I've already discussed, they act as the acetylcholine antagonist. Yes, they are antagonists. They can bind to the receptor, nicotinic receptor on the muscle, and block the receptor. Yes, by what mechanism? Competitive inhibition. They are competing with the acetylcholine for the receptor. The interesting story of the neuromuscular blockers is what we get from the substance curare. Curare is a very interesting substance that was discovered in by the scientists in the Amazon rainforest. Some native men in the Amazon rainforest, they were poaching, or they were hunting the animals through by their arrows, and their arrows, on tip of their arrows, they had curare. As soon as the arrow of the poacher or the hunter, the arrow hits the animal, the muscles of the animal, they undergone the paralysis. They saw that the muscle of the animals, they undergo paralysis. So this was the first neuromuscular blocking agent that was discovered by because the natives, Americans or jungle men there, they were using this, okay, to produce paralysis of any animal, and once the animal was paralyzed, they used to eat them up. So this is a plant derivative, curare. And when we discovered curare, we made other neuromuscular blockers, and then we started using them semi-synthetic. Okay, what are the other neuromuscular agents, non-depolarizing, that we used now is the tubercurare, curium. So most of them are ending with the curium, curare. So you say curare or curium, this means they are all derivatives of the curare. So tubocurarine, curium, pancuronium, mevacuronium. So wherever you find cure, cura, cure, so it means that they are all derivatives of curare, and they are what? Neuromuscular blocking agents, depolarizing type. Okay, so when we give them through the intravenous route, what happens is, the small muscles are paralyzed. For example, the muscles of the face, they're all small muscles, yeah, face, neck and all, they're all small muscles, so they get paralyzed first, and then the muscles of limbs and the what we say respiratory muscle, they also get relaxed, but later on. So the relaxation occurs from the smaller muscles and then the larger muscles, and when the effect of this neuromuscular agents is reversed, means when the effect is eliminated and when the muscles recover, then they recover in the opposite fashion. For example, the big muscles will recover first, and then the short muscles will recover later on. So these are the non-depolarizing agents. First, small muscles will be paralyzed, and then the big muscles. What type of paralysis is this? This is a flaccid paralysis. Flaccid paralysis means muscles are relaxed. They're like this state, very much relaxation. This is flaccid paralysis. And what is this? This is not flaccid paralysis. This is depolarizing paralysis. Yeah. See, that is produced by the tetanus. Tetanus doesn't produce the flaccid paralysis. Flaccid paralysis is produced by the botulism. So this is flaccid, and this is the paralysis non-flaccid, that is produced by the tetanus. Okay. Now, how can you manage the concentration of such neuromuscular blocking agents? For example, obviously we are giving them in the surgery and all those procedures. So sometimes we want muscle to be more relaxed, sometimes we want to be less relaxed, and sometimes we want muscle to be normal. So how can you reverse the action of these neuromuscular blocking agents? Obviously, if by somehow you increase the concentration of the acetylcholine in the cleft, because if the acetylcholine will be more in the cleft, the synaptic cleft, then it will exceed the amount of the neuromuscular blocking agent, and the acetylcholine will bind with the receptor and the muscle will recover. So what agents can be used to increase the amount of acetylcholine in the cleft? We have cholinesterase inhibitors. This is the enzyme acetylcholinesterase, very important enzyme. What does it do? It decays the acetylcholine in the cleft. So if you block this enzyme, the acetylcholine that is naturally in the cleft, it won't be degraded, and the concentration of the acetylcholine will rise. So acetylcholinesterase or the cholinesterase inhibitor enzyme inhibiting drugs can be used if you want to reverse the action of such neuromuscular blocking agents. What are such drugs? Neostigmine and the endrophonium. They are indirect cholinomimetics. I have already told you in the last videos. Okay, and these neuromuscular blocking agents, they have drug interactions. Means अगर आप उन्हें किसी drug के साथ दो, then the effect of the agents can be increased and sometimes it can be decreased. Decrease effect कब हो सकता है? When you are using cholinesterase inhibitor. So this is type of interaction they have. Okay, so uh, the effect can also be increased in the cases of desflurane. This is a drug that is called desflurane. Desflurane is type of halogenated anesthetics. Anesthetic, what does they do? They increases the binding of these neuromuscular depolarizing agents to the receptors. Means the receptors become more sensitized to these neuromuscular non-depolarizing agents, and if they become more sensitized, the receptors, so what will it produce? It will produce enhanced paralysis. So enhanced paralysis can be made or can be done by using halogenated hydrocarbons such as desflurane along with these blocking agents. Okay, then the other type of interaction is with the amino glycosides. Amino glycosides are some antibiotics. Okay, example gentamicin and tobramycin. These gentamicin and tobramycin also have synergistic effect. Means they will also increase the duration of action of the neuromuscular blocking agents, because they will also make the receptor sensitize and the effect will be increased. Okay, so we have discussed all the non-depolarizing neuromuscular blocking agents, and now we are going to discuss about the depolarizing muscular blocking agents. So depolarizing का मतलब क्या है? That they are going to produce depolarization. So they act, first of all, how? ये depolarizing neuromuscular blocking agents will bind to the nicotinic receptor. They are just like acetylcholine. Okay, when the acetylcholine binds, it produces what? Depolarization. So when these depolarizing agents, neuromuscular blocking agents, bind to the receptor, NM type of receptor that is present on the muscles, so what will they do? They will first cause the depolarization of the muscle membrane, and thus, initially, when the depolarization will be produced, what will happen? The muscle will contract, or some fasciculations will be produced. Fasciculation are like this. Okay, so muscles contracting because of first initial depolarization. After that, this is called as phase 1, when the muscle depolarization is produced and the fasciculation are seen in the muscles. After that, what will happen is that this agent that bind it to the neuron and the NM type of receptor, it will keep on binding to it, okay, for a long period of time. And because of binding of this agent to the receptor for a very long period of time, this receptor become desensitized for a period of time. So जब ये जो एजेंट है, द डिपोलराइजिंग एजेंट, जब ये रिमूव भी होगा ना रिसेप्टर से, so then the acetylcholine will try to bind with the receptor after this agent is removed. Yes, the acetylcholine will not produce effect, because जब acetylcholine bind करेगी the receptor से, the receptor was desensitized already because of the succinylcholine, that is type of depolarizing neuromuscular blocking agents. So second phase में क्या होता है? The muscle undergoes repolarization, क्योंकि पहले क्या हुआ था, जब बाइंड किया था सक्सिनलकोलिन receptor से, the muscle first depolarized. After the muscle depolarized, fasciculation was produced. After some time, what will happen? The sodium channels will close and the potassium channel will open, and because of opening of the potassium channel, the charges will go out and repolarization will be produced. Repolarization मतलब क्या है? Muscle is relaxed now, but when the muscle is relaxed now and succinylcholine is degraded by the enzymes, okay, Muscle is in the state of relaxation. Acetylcholine is degraded. Now the acetylcholine try to bind with the receptor, but because the receptor is desensitized, it won't be able to produce effect, and inability to produce effect will cause what? Flaccid paralysis. So this is how the depolarizing muscular blocking agents are working. First of all, by producing depolarization and fasciculation, then in the phase second by producing repolarization and the receptor desensitization. Okay, what is the adverse effects that can be produced by such agents? The most common adverse effect is apnea. Apnea is paralysis of the respiratory muscles that can be produced by the depolarizing neuromuscular blocking agents, and apnea may even result into the death of the patients. So these are not very much used commonly, but the effect of succinylcholine is very rapid, so it can be used when you want rapid intubation, you want rapid endotracheal intubation, and you want to produce rapid effects. Otherwise, these are not very much used in the clinical practice, in the surgeries or other procedures, but only in the case of emergency these are used. In normal cases, surgery and nasotracheal intubation, endotracheal intubation, you use non-depolarizing type of blocking agents. So that is all about them. Thank you for watching. Please like, subscribe and share our channel. Thank you for watching the video.